Good afternoon. Good afternoon. Can you hear me? No? Oh, I think we're going to start. It's around 4 o'clock. Thing is, it's a really great pleasure for me to introduce Dr. Andy Theodoro. I don't know if he needs any introduction. I think most of people who know him here at UMC, but it's always good to do some introduction. You think you know the person, but you really don't sometimes. He will be talking today about therapeutic hypothermia after pediatric cardiac arrest, and does hypothermia improve neurobehavioral outcomes. Dr. Theodoro, in child psychiatry we have a weighing machine, so we usually check weight of every or most of the kids, and then sometimes we have other staff come to us too because there's no other weighing machine in the department, I think. So I also weigh someone's CV who is giving the lecture. So it's pretty impressive and heavy. I really checked this on the weighing machine. He did his he did his MD from Wayne State University, and then pediatric residency. He was chief resident there. Then pediatric care fellowship, critical care fellowship at Wayne State. So he was in Michigan for a long time. Then he decided to come to Arizona, University of Arizona. I think he started here in '92, if that's correct, right? And since he's presently professor of clinical pediatrics, Chief Pediatric Critical Care Medicine, Associate Head Department of Pediatrics, Director of Center for Quality and Safety, Chief Medical Officer for UMC Diamond Children's, Chief Medical Officer Hospital Division, UA Healthcare. I don't know how he does that, how he can handle all these things. And he has received many honors and awards and has been included in Best Doctors in America a number of years. Got Best Teaching Awards. He's Fellow of American Academy of Pediatrics, Society for Critical Care Medicine, and he has over 50 publications, has several grants, and I can keep on going, but I think you want to hear him. So thank you, Dr. Theodoro, for coming.
Appreciate it. And with all that, I left out pediatric cardiac arrest on my title slide, so my background didn't help me get my title right. Thanks for inviting me, and I hope the topic will be interesting. I wanted to choose something that has some neuropsych implications and also is something active that I'm working on. And this is a study that we've just joined. But I wanted to ask you folks, how many of you have heard of hypothermia being used after cardiac arrest to improve outcome? There's a few people in the crowd. How many of you feel that when you heard about it, it is actually what is and should be done after cardiac arrest, keep people cold? Okay, I'm glad the hands didn't go up because one of the objectives here is to let you know that it's not really a done deal. It is a question. It's an open question right now. So I am going to review cardiac arrest in children, a little bit on the pathophysiology of the brain injury associated with cardiac arrest. I'm going to spend most of the time going over the current literature on hypothermia after cardiac arrest, both for adults and pediatrics. And then I'm going to go over the study that we're doing here and get you up to date on where are we at today. Now, cardiac arrest in kids. I can't even tell if this is really on, but you can hear me all right? Okay. Cardiac arrest in kids is the worst thing as a pediatric intensivist that I deal with. Oops, we don't need that. And did I just lose the whole thing? Let's see. Because outcome, as it is in adults, in out-of-hospital cardiac arrest is actually very dismal. We have the near-drowning patients. When I hear there's a near-drowning coming into the emergency room, my heart stops, because either it's going to be fine, it's going to be one of those 30-second things, child got pulled out and we're fine, or it's going to be a disaster. There's really not a whole lot in between. In-hospital cardiac arrest has a better outcome. We're here, and as a matter of fact, it's not just the promptness of being here, bless you, but we oftentimes get to interrupt before it becomes full cardiac arrest. It may be a little hard to see this. This is a recent study in Circulation. My good friend Bob Berg, some of you may know Bob, he used to be here. He's now at Children's Hospital of Philadelphia. This study, in terms of characteristics, you can see when you look at infants, children, and adolescents, the majority of arrests happen in the infants. Not only are they at risk for things like SIDS and handle respiratory problems less well, they're also, unfortunately, more easier to traumatize, child abuse and accidental. So a lot of the arrests happen. Actually, I was just looking for a pointer, but I guess I'll use this. And then if you look at the incidence compared to 100,000 person years, the infants are 72. Adults are about 90, 95 person years as an incidence. And then you can see that children in general, much less, and as are adolescents. Now, it may be hard to see. This is from the same study that looks at outcome. And this is unfortunate, but when you look at the successful outcome, the survival outcome of infants, out of those 275, it's only about 3% of out of hospital. 9% for children, almost 9% for adolescents. Overall, survival to hospital discharge in cardiac arrest, of out-of-hospital cardiac arrest, is very low. And that's about the same rate for adults in terms of the infants. And this is compared to adults. Infants are a little bit worse than adults. The children and the adolescents are better than adults. Now, how about in-hospital cardiac arrest? The good news is of in-hospital cardiac arrest, we have anywhere from 25 to 45, some studies even 50% survival after in-house cardiac arrest. But unfortunately, it doesn't stop there, because that's when we start talking about what's the neurobehavioral outcome even after successful resuscitation. Are there consequences? That question has not been well answered. This large study, again, from 15 sites, looks at the etiology of the cardiac arrest in kids. It's really important to note that unlike adults, and when we look at the adult studies, you'll see that primary cardiac events like VFib are the origin of the cardiac arrest in adults. That's not the case in pediatrics. And if we're going to look at the outcome and the treatment, we have to understand that the etiology is different. 72% had a respiratory etiology. By the way, for those of you that are following the latest, greatest in CPR and the chest compression only CPR that we teach here at the U of A, the reason why we don't teach it in kids is because of this. Respiratory events make up over 70%, and in those cases, you do need to breathe for them. So that's why we don't do chest compressions only in pediatrics. Now, after the cardiac arrest, the mechanism of brain injury is varied. There's excitotoxicity with the release of neurotransmitters like glutamate and stimulation of receptors, and that overstimulation in the neurons can lead to cell damage, cell death. You've got disruption of calcium homeostasis with the influx of calcium into cells, which we know contributes to cell death. And That's going to keep coming on. And probably, well, that's okay. Free radical formation. As a matter of fact, now people are even saying maybe we shouldn't give oxygen after resuscitation. Maybe we should just give room air because the extra oxygen may lead to the production of more oxygen radicals. That we're not recommending that officially, but in terms of mechanisms of brain injury, other pathologic protease cascades, and activation of cell death, like apoptosis, could be triggered by a cardiac arrest. So maybe cells that weren't primarily injured may go on to die because that mechanism gets turned on and cells die. When we look for the consequences of the arrest, we have to understand what parts of the brain are more susceptible to the hypoxia and the ischemia. The cortex and the watershed areas are very susceptible. The cerebellum has a high oxygen consumption, so it becomes sensitive to cardiac arrest during hypoxic states. The corpus striatum, thalamus, and the basal ganglia can get impacted and lead to some movement problems. The hippocampus tends to be a little more resilient, but somewhere between 15 and 20% gets injured during a hypoxic ischemic event. Obviously, the circulation is altered after a cardiac arrest with impaired autoregulation and the genesis of cerebral edema. Now, after having said all this, a lot of these mechanisms sound like the mechanisms we see in other brain injury, especially traumatic brain injury. Unfortunately, the treatment we use for traumatic brain injury doesn't seem to work for hypoxic ischemic. The injury tends to be relatively global, maybe more or less in these sensitive areas. But the consequences, it's pretty much a done deal. After the event, there isn't much we can do, like draining pressure and all the stuff you've heard us do for traumatic brain injury. Doesn't seem to work. The consequences, coma, seizures, persistent vegetative state, an acquired Parkinson-type scenario, cortical strokes, etc., everything you see on the slide. We don't seem to have a mechanism to prevent these things. They just happen. The longer the cardiac arrest, the more likely these things are, bless you, to happen. And certainly to go on to brain death is not an unusual consequence in severe or prolonged CPR. So here's a young fellow trying to use the latest techniques in neuroprotection after hypoxic ischemic events, getting his head cold. Now, this discussion got started because of those miraculous cases you've heard of. Child falls in a cold lake or stream, you know, back where I came from in Detroit. And they pull them out after an extended period of time and do CPR and everything is fine. Those cases, by the way, are exceedingly rare. But they have got us thinking, is there something about the cold that leads to protection? So, as much as we've heard discussions on being cold and after cardiac arrest and doing better, there really have only been a small handful of studies that look at the neuroprotection of therapeutic hypothermia. In 2002, there was 2 randomized controlled trials that looked at adult patients with VFib and VTAC. We'll talk more about those. And in 2005, there was 3 randomized controlled trials in newborns. You may have heard here in our neonatal intensive care unit the total body hypothermia that's being done for newborns born with cardiac arrest or severe hypoxic injury. That current treatment is based on these few studies, and I'll go over those. What you're not going to see is any real data that looks at children. I don't mean newborns, those tiny little ones that are hot out of the oven that have a problem, and those older than 18. That group in between, there's very little literature. Everything we do has been extrapolated from these other these other studies. Now, meanwhile, with that sparse of a literature, the American Heart Association and the International Liaison for Cardiac Arrest, the ILCOR group, have made these relatively strong statements initially, actually. Therapeutic hypothermia after cardiac arrest is recommended in all unconscious adults after VFib and out-of-hospital cardiac arrest. That is the recommendation for adults. Now, I'm not going to talk a lot about it, but I'm going to show you the articles, and you may raise an eyebrow thinking, wow, based on 2 studies, we made such a strong recommendation. Insufficient evidence to make a consensus statement for pediatric cardiac arrest, but in the current guidelines that came out, American Heart Association for Advanced Life Supporting Kids, they actually say consider it. Those of us involved with this national study, actually it's international, it involves Canada, we actually didn't want them to put the statement in there because, as you'll see, we're not convinced yet. So the first big study that came out was in the adults was from Australia, published in the New England Journal in 2002. All those patients had ventricular fibrillation. Again, already a little bit different than pediatric patients. They had return of spontaneous circulation at 12, before coming in the hospital, in the pre-hospital setting. They were kept at 33 degrees for 12 hours and then rewarmed over 6 hours. And their definition of good outcome was being discharged home or to rehab. Bad outcome was death or discharge to a long-term nursing facility. That was about as fine-tuned as their neuro outcome was. Now, interesting thing about this study was it was initially powered to have 62 patients in it, 31 in each group. And when they got there, there was a trend, but no significance. So they kept going. And they enrolled another a handful of patients, up to 77, 72 of which actually met the correct treatment. And at that second analysis, they reached statistical significance. The next big article that we've based some of this on came out also in '02, also in the New England Journal, put out by the Cardiac Arrest Study Group. 9 hospitals, this was out of Europe, 5 European countries, also VFib was the origin of the cardiac arrest. Patients had return of spontaneous rhythm before arrival to the emergency room, kept between 32 and 34 degrees for 24 hours with passive rewarming over 8 hours. And they were looking at favorable neural outcome in 6 months with secondary outcomes of mortality and complications within 7 days. Now, this is interesting, and this is a theme I'm going to go back and forth to. You can see the control group, the bottom loop, was kept cold around 33. The normothermia group, or the control group, was allowed to have whatever temperature they were going to have. They weren't controlled at all. Unfortunately, the T-bars represent 75 75th percentile on the top and 25th percentile at the bottom. And when you draw the line at 37.5, 25% of their normal temperature patients actually had fever. And we know from the critical care literature that fever actually leads to more brain injury. Basically, whatever your problem is, could be sepsis, could be brain, it could be trauma, could be hypoxia, it seems as though fever leads to a worse brain outcome. But in this case, the control group actually had fever. They didn't have a description of their power calculations ahead of time, and their functional assessments were not blinded. The functional assessment was blinded to group, but those doing the examinations knew the final results of the study. So you got to take that with a grain of salt. Those were the 2 main adult studies that led to the recommendations to provide hypothermia after cardiac arrest. Now, going to the neonatal studies, this first study in '09, so a relatively recent study, looked at moderate hypothermia and perinatal asphyxia. randomized at less than 6 hours of age, moderate hypothermia, 33.5, for 72 hours, and the primary outcome was death or severe disability at 18 months. Secondary outcome were 12 assorted neurologic outcomes based on a neurobehavioral battery of tests. They also looked at 14 safety indicators. Well, here we go again, the control group, and you can see the variation in temperature. A significant amount of the control group, which was supposed to be kept here, actually were in the febrile range. And not only that, these time points you can see 4, 8, 12, 16, 20 hours. They did not capture the temperature fluctuations in between those time points. So on both groups, we don't know who might have spiked a fever during those time periods. So, and what about the results? This was called the Toby study. They showed, actually in their conclusion, that they did not show a reduction in the rates of death or severe disability, but they did find some benefit in some of the secondary neurobehavioral tests. But their primary outcome goal of severe disability and death was not different between the two groups. Another paper, New England Journal of Medicine. Again, you notice these are all very well-reviewed, published in good journal papers. But when you look at them critically, this one here, whole-body hypothermia, lead author Sitha Shankran, who I know very well back in Detroit, and is an outstanding investigator. This study with whole-body hypothermia did show improved outcome, and that was their primary outcome point. They showed a decrease in death or moderate or severe disability. None of the other secondary outcomes reached significant. This is probably the best article looking at neonates with the primary outcome reaching significance. But look at their control group again. Their control group had variation and probably also had higher temperatures than normal. Looks like they went up into the fever range as well. That's the 37-degree mark there, and you can see most of their patients with the deviation were significantly higher than that. The third study in neonates looked at selective head cooling, the so-called CoolCap study, and that did not show significant outcome basically on any of their outcome parameters. What they said in their paper was it's doable and we can do it safely, but they didn't show an improved outcome in any of their outcome indicators. So one of two studies that looked retrospectively to pediatric patients, it was not a randomized control study, it was just looking back at patients that were outside of the neonatal period that survived resuscitation. This paper basically found a worse outcome, but said it's doable and should be reviewed. And the study by Erica Fink out of Pittsburgh, who's also part of the current study, showed that there was no difference between groups looking at hypothermia and controlled temperature, normothermia. So where does that put us? Well, if you look at a little bit more on this last study by Erica Fink in Pittsburgh, you'll notice no difference in mortality, but you do see the wide variety of the etiologies of cardiac arrest in kids, again, to emphasize how difficult this is to study. Unlike adult cardiac arrest, where most people have VFib and then go into cardiac arrest, a uniform type of disease. In pediatrics, you can see the huge variety of origins. Ultimately, it's asphyxia that most kids die from. And once again, if you look at that bottom row in the study that looked at by Dr. Fink, again, fever was a common finding in both groups. So what does it mean? Does hypothermia, I mean, I'm sure those of you that raised your hand, thought the data would be better than this. We're talking about 2 adult studies that were in fibrillation in Australia and Europe, and then 2 out of 3 studies in neonates that showed some outcome improvement, and 2 retrospective studies in pediatrics, one that showed worse outcome, one that showed no difference. So really, where are we at? Well, I'm going to play you something, which is...
We're back now at 8:09 with a medical miracle. 1-year-old Bronson Staker was left unattended in his bathtub and drowned. When he was pulled from the water, he had stopped breathing and had no pulse. But that is just the beginning of this incredible story.
So it was just a typical Saturday morning here at our house.
It was Sarah Staker's worst nightmare. While giving 2 of her sons a bath, the young mother briefly stepped away to do some chores, got distracted, and when she returned, the unthinkable. Her youngest son, 16-month-old Bronson, submerged in the tub.
He was white. His eyes were rolled back in his head. His lips were blue, and the bathtub was so full.
Sarah's frantic attempts at CPR didn't help Bronson. Even the EMTs couldn't revive him. When they reached the hospital, there was no pulse. Bronson was not breathing.
He was just gone. It was so fast, and I just wanted to rewind. I just wanted to do it again, and I just kept begging, please, baby, please, please wake up.
Doctors struggled to restore the child's heartbeat, eventually succeeding.
Our sweet little boy laid there with a tube in his mouth and wires and IVs, and I can't even count how many things he was connected to.
But with Bronson still in a coma, doctors suggested the Stakers try an innovative therapy called therapeutic hypothermia, using cooling blankets to drop his body's temperature and hopefully prevent brain damage.
This is keeping your body temperature cool, but not so cold that you're preventing all your organs from working well. But it's really just an idea is to keep the brain from all the cellular processes that can then worsen your outcome from happening.
As Bronson lay unconscious, his mother began putting her thoughts and emotions into words, writing a blog about the ordeal.
We're trying not to think about the what ifs and what thens, but are taking things hour by hour. We're still praying for a miracle.
For nearly 2 weeks, nothing. Then, a miracle. Bronson woke up, alert. He started to regain mental and motor functions.
You could see it immediately, lifting just a little bit with his chin as he leaned forward, and he recognized me when I walked in the room.
Slowly but surely, the boy thought to be lost forever improved.
And they told us that Bronson would have to leave the hospital in a wagon, that he wasn't going to be allowed to walk out of the hospital.
So I think you get the message that what we're fighting with trying to really answer the question is a feeling in the community and even by the other physicians that we work with that we have the answer. That hypothermia is the miracle that's going to save the brain after a serious cardiac arrest. And interestingly enough, this particular case was at Primary Children's in Utah. They're one of the main sites where this research is being done. And they actually give the investigators this video to warn us not to go out and say that the answer is because of the hypothermia. And what I want you to think about as now I talk about the study is if the community of physicians, let alone the community of parents, feel that the question is answered, where's the equipoise? How do you go in and you say, we are going to randomize into 2 groups. One group gets hypothermia and one group gets normothermia. And unless we get the answer to this question, we're going to be basically doing a therapy which may or may not have value, which may or may not have complications because of a collection of literature that is really not only sparse, but not necessarily well done. Now, I will tell you that it might be the right thing to do, but what we don't know, and I think what I wanted to show in the literature is the enemy might very well be fever. Not that the answer is hypothermia, but that the answer is don't get a fever. That's why the two limbs of this study, and this is our, as we go through the study real quick, this is the study team. The PI is out of Michigan, Frank Moeller. He's head of the intensive care unit at Children's Hospital of Michigan, or Mott Children's. And we have a variety of local investigators, and Joanna Katsanis from your ranks is helping us with the neurobehavioral testing after, as I'll show you, after a year of having CPR. The sites that are participating in this study are all the who's who in children's hospitals around the country. We really feel this could be one of the landmark articles that really answers the question, because basically all major centers are now participating. The primary research question is, does therapeutic hypothermia improve survival and long-term neurobehavioral outcomes from cardiac arrest in children? There's going to be two limbs. One is out-of-hospital cardiac arrest, and the other is in-hospital cardiac arrest. And we're also going to look at safety. The primary complications of hypothermia that people worry about are infection, arrhythmias from being too cold, and bleeding because of coagulopathy associated with hypothermia. The 33 degrees should not cause any of those things, but those are the major concerns, so those are the things we're going to look at, and an additional all-cause 28-day mortality. So very simple design, one intervention, hypothermia versus control, out of hospital, in hospital. But I emphasize, and if you look at the control, it's 36 to 37.5, tightly controlled, actively controlled, with the same blanket that controls the hypothermia. It is not a passive control group. So when we consent a family, if they meet inclusion criteria, they have to have CPR for at least 2 minutes. They get back their rhythm. They have to be outside of the newborn period, at least 48 hours old, and under 18. And they're unconscious, requiring mechanical ventilation. Lots of exclusion criteria, and I will tell you, if you happen to be in an area of the hospital where there's a cardiac arrest on somebody under 18 years of age, we want to know about every single cardiac arrest that happens in this hospital that's under 18 years of age, and then we will screen them to enroll them in the study. But the informed consent is tough, because if you look at the neonatal studies, if there's any benefit, you have to start the cooling within 6 hours. So think about this from an emotional state. A parent just had their child with CPR and might be comatose. Well, they will be. If they're in the study, they're going to be in a bad way on a ventilator and comatose. And then you're going to have an investigator that's going to come up and try to get informed consent on hypothermia or no hypothermia, with an explanation that they're both treatment groups. Basically, one is being kept purposely normal but with no fever, and the other group is going to be purposely kept cold at around 33, and to try to assimilate that right after your child has had cardiac arrest. So it's a difficult study to do. Interestingly enough, around the country at all these centers, there's about a 75% plus acceptance rate when being confronted by the investigator, and we're trying to keep the investigators separate from the treating doc. Now, there's only 2 of us that are considered investigators at this site, and there's only 7 intensivists between us, so there's a fair chance that one of us will also be treating. But we think to train somebody to get consent under these circumstances is very hard. And there aren't a lot of, fortunately, cardiac arrests. So we're basically 2 of us that are available 24/7 to come in and consent the family. We have pamphlet which explains things in addition to the consent form. Because it's a big national study, there's a lot of experience in terms of how to approach the families. The first case I had, I got turned down, and I couldn't blame the family. But at any rate, the two categories, the two treatment groups, therapeutic hypothermia, as I said, is 33, between 32 and 34. We have a special blanket. It's auto-controlled. It's really, really tightly controlled. We have two temperature probes. One is esophageal, and one is bladder or rectal, so we have central temps to make sure we control the temp. Now you see that we also give sedation and neuromuscular blockade. The shivering that happens as you cool, which is regulated by the hypothalamus in an attempt to keep warm, can often prevent us from dropping the temperature. The body is actually pretty good at trying to keep the temperature up, so you basically have to paralyze to take that out of the equation during the first hour while you try to drop the temperature. Otherwise, sometimes you can't get the temperature down, and you have to drop it quickly in addition to the blanket. So we sedate, we paralyze, and we use a blanket both above and below the body to bring the temperature down. Those in the normothermic group also have a blanket, but they don't get paralyzed. They just get sedation. There's really no need for neuromuscular blockade in that circumstance because we can keep normal temperature just fine, even though there may be some shivering that goes on even at 36 degrees. By the way, when you get to 33 degrees, the shivering mechanism subsides. For some reason, when you get the temperature down, again, it's a hypothalamic regulatory thing that shivering stops. So that's why we only need it as the change in temperature is occurring. So both the hypothermia group and the normothermia group are kept at their temperature, and then for 120 hours total, they're kept at normal temperature, and that's the duration of the study. I will emphasize that when you go from cold to normal, it's probably one of the most dangerous physiologic times of the study because potassium is changing. Initially, potassium drops when you get cold. When you get warm, potassium increases. There's risk for arrhythmias. Blood pressure changes. When you're getting cold, blood pressure goes up, heart rate goes down. When you're getting warmed, vessels dilate, and blood pressure can drop. So these transitions are very tightly controlled. What is the follow-up? At 3 months and 12 months, we have the follow-up. At 3 months of age, the family is contacted by the Kennedy Krieger Institute, an investigator there. Are you all familiar with the Kennedy Krieger Institute? It's a very specialized neurodevelopmental clinic in, I believe, in Baltimore. And we have one investigator who's part of the study, and she will do every single evaluation, the VABS-2 survey, which I'll show you in a second. It is so important to have a consistent measurement at 3 months and 12 months. One individual person will do these studies of all the patients, and so far, nationwide, we have just under 200 patients enrolled thus far, and she has done every single evaluation. And then also at that point determines the well-being of the patient and with a variety of scores. If that patient is felt to be okay, the same survey is done at 12 months with phone interview from the same person at the Kennedy Krieger Institute, and then she determines if the patient is okay enough to go on to the next evaluation, which is an on-site neurobehavioral assessment, which Joanna's going to be doing for us, and also an on-site neurologic evaluation. And our neurologist is going to be Dr. Janet Teodori, new in our practice here. At any rate, but they'll get the green light after KKI does a screening evaluation. Based on adult studies, the things that we suspect will happen in post-cardiac arrest scenarios. Again, the watershed, cerebral cortex, and basal ganglia are most frequently damaged. So we'll look for changes in those areas, both the neurologic and psychologic. Memory is like in traumatic brain injury. Memory is a big deal, but it's usually associated with something else. A smaller amount, 19%, as you can see there, has only memory disturbance. Personality and behavioral changes are very common. Again, things that you all might be seeing in your practices. Visual, spatial, visual recognition problems, very, very common. And the kicker with hypoxic ischemic injury compared to traumatic brain injury, it tends to be static, whereas with traumatic brain injury, we tend to see changes over 1, 2, 3, even 5 years, we see changes. Hypoxic ischemic injury, a more global event, tends to be more what you see is what you get, and a little more frustrating to follow, which again makes that therapeutic hypothermia so important. I will tell you in pediatric literature, hypothermia in traumatic brain injury in a recent article has led to worse outcome in terms of the brain recovery and mortality, actually. Whereas in these few articles that we did look at, we didn't see that except for that one article that had worse outcome. So at any rate, but because the improvements are so weak over time, it makes that initial therapy that much more important. And again, memory deficits, behavioral personality changes, very, very common. How many of you here are familiar with the Vineland-2? I imagine you folks in this room could tell me more about it than I can tell you. But the reason why it was selected to evaluate the patients at the 3 and 12 month is it's very easy to do over the phone by a trained investigator. It's a very consistent, it has good reliability, and able to actually be fairly sensitive to severe brain injury, has a good discrimination at low and high end functioning, was recently updated, Vineland-2, and again can also use clinical data to fill from the charts to fill in missing data when necessary, and it does have a continuous score. And I'd be willing to get comments at the end from those of you that use this particular test to see if you think it's a good or bad study. The neurobehavioral batteries which are used, the Mullen scales of early learning, ages 12 months to 5 years and 8 months, good general intelligence intellectual development tests. How many of you are familiar with these tests? Okay, some in the audience, good. Now, the older kids, greater than 6, use this battery of tests, and I imagine all of you that have raised your hands thus far will raise your hands again that these are tests that you use. You notice, though, that there's a bit of a gap, 5 years to 8 months, and then 6 years. The reliability within that 6-month span of these tests is so poor that the decision was made to not test kids if they're 5 years and 8 months, and to wait and then test them when they're 6 years old with these tests to get a better idea on how they're doing. So again, the major study outcomes, the VABS-2 survey taken at enrollment, taken again at 3 months, and then again at 12 months. The VABS-2 taken at the time of enrollment is also a bit problematic because we get it from the parent who's now dealing with a newly resuscitated child. But if we don't get the VABS at the beginning, the patient won't qualify for follow-up. So again, it's a tricky part of the study. Neuropsych battery at 12 months, and neurologic score at 12 months. and the safety that I mentioned earlier. So where are we at the study? The enrollment began September of '09. There are 31 U.S. and Canadian institutions. And as I mentioned, equipoise became a serious problem in the trial institutions because even the investigators, the colleagues of the investigators at the study sites didn't feel comfortable not providing hypothermia after cardiac arrest because the general feeling was you got to do it. Because the American Heart Association said you got to do it in adults, the feeling was we got to do it in kids. But the slides that I showed you in actually quite a bit more detail, I send them to the investigators, I send them to my colleagues, and I say, don't take my word for it, look at the literature. We don't know the answer to this question yet, but it needs an answer, so, you know, work with me. Because what would happen is as soon as a parent would say, no, 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 I don't want the study, the investigator would go and do hypothermia automatically. And as a matter of fact, if you're a study site and you do that, you'll get tossed out of the study because then you're not going to have clean, reliable data, and we won't be answering the question again. Here's where we were at the beginning of this year. You can see the enrollment has really taken off and actually is beating projections, and now we're up here, we're just under 200. So enrollment is picking up. Our colleagues at PCH and Phoenix are also part of the study. And we were very happy that hypothermia came to Tucson. We actually tried, that's actually my backyard. But we tried, we waited to get on board for about a year. We waited because we had to confirm that we could get them enough study patients. Interestingly enough, we've screened basically 1 or 2 patients a week. And with all the exclusion criteria, we haven't had anybody that's been enrolled for the total duration. But we screen a fair amount of kids. If you're interested in more details, www.thapka.org. And it's a pretty comprehensive site that has more details on the study. So with that, I'd be happy to entertain questions. Yes?
I was wondering, I know you sort of alluded to what people are trying to do, but what is the standard treatment in these cases if parents who don't want to participate in the study?
That's actually a great question. The standard of care has become now aggressive normothermia, avoid fever at all costs. That's our standard of care, not to do hypothermia. I will tell you, before we got involved with the study, we were doing hypothermia. And we weren't doing it in a very controlled way. We were doing it all a little bit differently. And I think both from the possible complications, especially arrhythmias and electrolyte abnormalities, if you do hypothermia, you should do it with a careful protocol. But in reality, based on known outcomes and risks, avoiding fever is the prudent approach, and now we're all on the same page, and that's what we do. Yeah?
The Stanford football team uses a cooling device that you put the hand in a vacuum and there's a heat exchanger, and it apparently drops core temperature rather rapidly. Now, I don't know if it can go into hypothermia, but I wonder if that's been looked at for this kind of use.
Well, you know, another good question. Because of the buzz that hypothermia is the thing to do, there are all kinds of commercial products out there that can cool quickly. As a matter of fact, you can pay your fee as an institution and send a team to any one of a dozen places around the country, and they will teach you how to drop the temperature in a post-arrest situation very, very quickly, and probably sell you a gadget of some kind that will do it. But they actually have courses on how to do hypothermia quickly. Now, I almost put the slide in, but it's a little over the top, so I didn't. But there's a slide, the group in Australia, what they did as patients came in for their hypothermia study. In the field, they would tell people, whoever has a cardiac arrest, get everything out of your freezer and throw it on them. So patients would come in with like frozen vegetables and you know, all kinds of stuff. And there's a picture on the gurney of a patient that has, you know, frozen vegetables on them, and that's how they come in. Because the sooner you start, the quicker you can get it done. But there are gizmos that do just the head. There are some that do blankets. The ones that we use are a wraparound. And the one that we use is given to us by the study, and it's different than the one we actually carry in the hospital. And they will only let us use that in a study patient. Otherwise, we have to use the blanket that the hospital carries. Yeah. More questions? Yeah.
I have a question, like maybe you already mentioned, like from hypothermia to hypothermia, how much duration, like what kind of time frame you can, you know?
Yeah, we like to take at least 12 to 18 hours to warm them because you want to do it slow to avoid the consequences, the vital sign changes. So it's a very carefully timed. Yeah, definitely. And actually, I think the official number is 18 hours that we aim for. The thing that the problem is, and you saw it in the studies, if left to their own natural changes, someone that had a cardiac arrest will get a fever, almost always. So even while you're warming them, you're actually fighting to keep them cool, because otherwise they'll spike a temp in no time, and it can happen like that. So it is really, it really is an active warming process, and we would struggle to keep it into 18 hours.
I have one more question. When you're asking for consent, are you asking for the study, or you're asking specifically for doing it?
Yeah, we tell them that we don't know which they're going to get. We consent them for the study, and we tell them it's randomized. We call a number. They tell us what's going to happen. We don't know ahead of time. We tell them, though, that no matter which limb they're on, keeping them normal is an active treatment, because that is something we do very consciously. If you're not in the study, that's what we would do. We don't leave it to whatever happens, because we know that's probably bad. But they are told it's going to be randomized. And if they happen to see this thing on TV, and they say, no, I don't want to be in the study because I want hypothermia, we need to be able to tell them, but that's not our therapy, because we don't know if it's good or bad, and we don't know if the complication rate is more. And, I think I've seen a case have an arrhythmia while being warmed, so I think the question needs to be carefully dealt with. Yeah?
So are there more refusals to enter the study because parents are opting out for hypothermia and they don't want to take a chance?
Yeah, we don't actually offer that as an option. We tell them standard of care is... Oh, exactly right. That was the #1 reason that people refused when the study first started nationwide, that they opt out of the study because they wanted to get hypothermia. That's exactly right. Yeah.
Do you use a temperature control device to maintain normothermia, or?
Yeah.
Or yeah.
Same blankets. The exact same blankets are used, it does take a lot of work to just do that, because the natural tendency is to be much higher.
But you don't need sedation.
You need sedation, but we don't give paralysis. But we still use sedation. All right. Thank you very much. I appreciate the invitation. I hope that was good.
Yeah, good to hear about this. We usually don't